Okay, thank you for patiently waiting as we were allowing everyone the opportunity to log in and join us today. My name is Beth Scott. I am the program specialist over substance use disorder. PT 93, the currently 17215, and the 1115 waiver. Hello, thank you for attending today's public workshop for the proposed state plan amendment of the 1115 waiver substance use disorder services, edits to the intensive outpatient partial hospitalization programs and medication assisted treatment services, as well as MSM changes. My name is Beth Scott. I am the policy specialist for substance use disorder treatment, medication assisted treatment, and the 1115 waiver services and the behavioral health benefits coverage unit. Today, we're going to talk about the proposed state plan amendments for the residential substance use disorder treatment, coverage, and bundled rate services. We'll briefly go over the changes to MSM 400, as specifically the substance use disorder coverage was migrated to a new chapter. Preview the new substance use disorder treatment policy MSM Chapter 400, which will be titled Substance Use Treatment Services and Coverage. We'll do an overview of the new provider type 93. We'll leave some time for questions, and finally, we'll allow for public comment. If you have additional questions, please feel free to contact me directly. We've allowed 1 hour for our public workshop in total, so let's get started. The state plan amendment package that Nevada will submit to CMS contains 4 parts. Nevada has requested 2 state plan amendments, one for residential substance use treatment coverage and a second for bundled residential rates. The third request is for change to MSM 400 and finally the implementation of the new MSM 4100. These changes are intended to align substance use policy to state plan. The state plan coverage pages to be amended are page attachment 3.1A, page 6B.4 continued page 1, and we've created a new page numbered continued page 2. Within these coverage pages, Nevada defined residential substance use treatment as a covered service, clarified what services may be included in a PHP IOP, and requested to remove MAT from the PHP and IOP bundled services, thus allowing for the medication assisted treatment to be provided and billed for separately. Nevada defined residential services as residential substance use treatment programs that provide individuals in recovery from substance use and co-occurring disorders a safe and stable 24-hour setting that is staffed by designated addiction treatment personnel. Within a regimen of care that is planned and structured, skill restoration and counseling services are provided on site. The type and intensity of service is determined by the patient's need and must be clinically appropriate and medically necessary through prior authorization. Residential settings must be SAPTA certified. Nevada Medicaid will cover ACAM levels 3.1, 3.5, and 3.7 WM. You'll notice that 3.2 WM was removed from the coverage. This is because of changes that are coming with the ACAM 4th edition criteria. Nevada Medicaid will continue to follow SAPTA certification guidance and will remain using the 3rd edition of ACAM and switch to the 4th edition once SAPTA begins certifying with this criteria. The new bundled rate for residential substance use treatment is proposed to be added to state plan on page attachment 4.19B, page 3K. Listed here are the proposed bundled daily rates for ACAM Level 3 services. As Medicaid is no longer covering 3.2 WM, the rate that would have been proposed for this level of care was absorbed into the remaining levels to increase the bundled rate for 3.1, 3.5, and 3.7 WM. Changes to current MSM 400 currently titled Mental Health and Substance Use Treatment and Coverage Services, are being proposed to remove substance use language from MSM 400 and move it into a new MSM chapter dedicated to substance use treatment only. This change will hopefully make policy easier to find and follow for the end user. At a glance, here is a chart of the changes being proposed to the MSM 400. In addition to the title of the chapter changing to Mental Health Services, language for SUD treatment and services was removed throughout the chapter. The bulk of these services were listed in 403.7, 403.10, Attachment B, and Attachment C. The title of the new MSM chapter, MSM 4100, will be Substance Use Treatment Services and Coverage. Here is a list of the sections added to MSM 4100. This chart is the visual of what provider type 93 will look like. With provider type 93, a provider will have a choice of 3 different group enrollment specialties. 707, Substance Use Treatment Clinic. This will function like the current Teen 17215. You'll have the same codes, same billing, same enrollment requirements. You'll have a 93708, which is the opioid treatment program. This will function like the current 17171 methadone clinics. Again, you'll have the same codes, same billing, and same enrollment requirements. And the new waiver population, 93704, this is the residential substance use treatment in an institution for mental disease. A 707, 708, and 704 will be able to provide services that align with their levels of care and in accordance to their SAPTA certification. With the exception of 707, that will be able to also provide mental health only services, as they do currently with 17215. What's new with the provider type 93? Providers listed in the box at the bottom of this chart who will be performing the services will be required to obtain their own unique NPI and link through Medicaid to the group specialty. When billing is submitted, the group will be the biller and the individual will be the performer. The performing provider will be attached to the claim. We have developed enrollment for the 6 new providers, which are listed at the bottom in red. They are the peer recovery support specialist and the alcohol and drug counselors and their interns. CSWIs, MFTIs, and CPCIs are not allowable interns in PT 93. If you are utilizing these interns, they will need to pursue dual licensure as an alcohol and drug counselor and enroll in PT 93 accordingly for their services to be reimbursed by Nevada Medicaid. We have added alcohol and, that's a repeat. We've added, just as a side note, we've added the interns for the alcohol and drug counselors. The go live date for PT 93 is July 1st. This means the application will be available for access by all providers. There will be a 9-month transition period to allow enough time for providers, the groups, and the individuals to enroll in PT 93 and for Gainwell to process the applications. Providers will want to submit their new PT 93 applications as soon as possible. For those who are currently receiving grant funds for residential services, please check with your funding body as to their timeline for assistance. One of the most frequently asked questions I get asked is, what can I do now to prepare? Here's a list of a few suggestions that I've compiled for ideas that may be helpful as we quickly move towards July 1st. Prepare, don't panic. Enrollment is the enrollment for 93,707 was modeled after the enrollment for 17,215. So it's everything you've already had to submit for enrollment as a 17,215. It's just all on the checklist. Did I just get kicked out?
No, you're still on, but now you're sharing the all of us screen. So you're not your PowerPoint.
What happened? Okay.
There you go.
Now I don't see my PowerPoint. Okay.
We see it.
Well, I've lost my notes. Okay. We're gonna wing it this part then. Ensure that all new staff have applied for their NPI if they don't currently have an NPI. This is in specifically going to be for the new providers performers that we've added to the list of providers. Gather their documents for the for what would be necessary for enrollment, and just kind of keep those handy. For the agencies or the groups and for the individuals. Sign up for the Nevada Medicaid listserv. If you have not yet done so, I provided the link here on the PowerPoint that is posted to the website as well. Pay attention to web announcements via the provider portal. Training started yesterday from Gainwell. They're walking through the enrollment process. I encourage you to attend those trainings as they're offered. I think they're scheduled weekly, maybe bi-weekly at some points. I would encourage you to double check the schedule. And then this brings us to the conclusion of the presentation for the 1115 waiver MSM changes, IOP edits, and PT 93. So I will open the floor for any questions or discussion.
Hi, Elizabeth. This is Esther Quillisi. Do we access the recording on the website?
I think it'll be on the website, Sarah. I'm not sure. Do you know how that happens?
So usually it does take some time for us to get the recording and then be able to post to the public. I don't think it gets posted like on the public notice website. What we've been doing in behavioral health is posting our recordings on our behavioral health webpage. So we can send that out, the recording out when it's available. Looks like Lana's got her hand up.
Yeah, I guess I'm just a little bit confused about, because we're at the very end of June and, we're going to supposedly roll this out on July 1 or July 31st. I don't know. But when I see that it requires, all of our clinicians have their own NPI numbers. But under 17,215 and 17,188, we enroll as an agency as opposed to individual clinicians billing Medicaid for the services. Is that going to change in residential? Because I guess I'm getting a little confused on the requirements of provider type 93.
So Lana, I apologize for confusion. The answer is under provider type 93, your groups will have to enroll. So your 93, 708. Let me see if I can go back to that slide. So your 707, 708, and 704s will have to submit enrollments just like they do currently. This is the group. And then the individuals performing the services, so the clinicians who are rendering services, have to also enroll and link to the group.
So when you talk about a bundled rate for residential 3.5, we're going to bill that as an agency, am I correct?
Yes, that is correct. The agency is the biller, and then the claims need to have the performer who's leading the services needs to be listed on the claim.
Well, it's when you're in residential and you're required to have like 27 hours of services in order to qualify for true residential services. How can that happen when you've got a bundled rate? I guess I'm getting caught up in having individual clinicians doing billing for a one-day rate. That's the part I'm confused about. Are you guys planning on doing it like the CCBHC shadow billings, or I'm not exactly sure how this is going to work out, because not just one clinician touches that client in 24 hours, it's multiples.
Beth, would you like me to chime in?
Yes, please.
Okay, thank you, Lana, for the question. So, as Beth mentioned, the performer that's leading the overall bundled service would be the one that would be the performer on the claim. So your agency would bill, but then there would be perhaps maybe your clinical supervisor is made that bundled rate may be bundled or may be reimbursed under, but then the whole obviously reimbursement will go to the agency, but it will need to include an individual on that claim. So it was likely the person leading the overall service responsibility of the service being delivered for that individual. And then on the back end within your systems, each provider, so if you have like a peer support provider that's doing peer, and then you've got a therapist doing counseling, they're all going to have their separate notes within your system as to the pieces that they did as part of that residential program. But it's really going to be the person responsible for the overall services that would be the individual on the claim.
So the primary counselor.
Yes.
Would, or the clinical director here, however
Yes.
we would make that determination.
Correct.
Okay. And then I had another question on pre-authorization.
Mm-hmm.
How are these services for 3.5 going to be pre-authorized? I'm not sure about that yet either.
Yeah, so there's kind of two pieces to this. We wanted to provide a public, like an overall public workshop on all the changes, but there is two pieces moving forward. So you've got your PT 93 that's rolling out new provider type for enrollment. And then we, on the Medicaid side, we have to submit a state plan amendment to get these bundled rates with the bundled code. So there will be further directions coming once we have that approval of a prior authorization, an overall prior authorization for someone that's entering 3.5. So that may be for like a 30-day timeline. We haven't pushed those requirements out yet because we have to get approval through CMS to actually reimburse for one code for those services. Right now, it's all based on individual service at this time.
So we don't have final approval on the bundled rates yet.
Correct. We do not have final approval. What is happening is that's going to our July 30th public hearing. So we're going to present what we're proposing to CMS with the bundled rates that Beth had shown. And that's our start date of when we work with CMS to get approval for that. So that will be coming later. But the effective date of the bundled rate we're shooting for a July 31st effective date. That doesn't mean the CMS is gonna approve it by then, obviously, but it can be retroed back to that date.
So what do you mean by go live for July 1?
The applications, Esther, thank you for that. The application will be available on July 1st for providers to enroll.
So that's specific to the provider type 93, not the bundled rates for the 1115. So again, like the two separate pieces of it. Does that make sense?
I don't know. It does. I'm confused.
Okay, so currently beginning July 1st, that's when provider type 93 will be available for providers to enroll in. Right now, it's all going to be reimbursed based on individual codes, just like 17215 is currently. The second piece to that we have to get approval from CMS on is applying a bundled code for those ASAM level 3 levels of care. Because we don't have authority to pay a bundled code right now. So that's what we have to get approval for, and that's coming in the future.
So Sarah, and then things other than this new application will be handled as they have been. Is that correct?
Yes, so that's why that's why the enrollment piece, the new PT 93 has more of a transition period for it. As you're working with each agency functions very differently, has different amount of people tied to it as well. So that's why we're allowing for that 9-month transition. So everything is as is right now, but we would like you to start working on your new enrollments beginning July 1st.
Well, you worked hard. I didn't really see this day coming this soon.
I can. Well, thank you, Esther. I
It's
never
been a
thought it would
steamroller.
come either.
Angela, thank you for patiently waiting. I see your hand.
Yeah, I just wanted to know, I have two questions. The first are, Beth, are you going to run through the chapter at all on this call?
It's not in the slideshow. If there's something specifically that we want to see in the chapter, I'm going to lean to Sarah. I think I can do that, right? Yes. Yes.
Okay.
100%.
I don't think
Okay.
I'll bring anything up yet, but my main concern, which, you know, I Beth and Sarah, you guys know, you talk to me a lot. My main concern, I'm sure the other providers agree, where are the MCOs in this process? Where are their deadlines? Do they know? Are they ready? If we get started now and we get approved, are they ready? Is there going to be a gap there? I mean, all the MCOs I've talked to act like they know virtually nothing about this transition.
Unfortunately, I cannot speak for the MCOs. I can say that I have reached out to all of the MCOs. All of them individually have offered to meet with them individually during our quarterly meetings, individually more as needed. So the changes should not be a surprise. I would encourage each of you who may have MCO questions to start reaching out to your MCOs and ask them, encouraging them. If they don't know the answers to your questions, give them my email address and say, please email her and ask. I understand it that they credential everybody this way currently. So I don't know if they're anticipating a huge change in their process, but I don't work with the MCOs in the capacity that you guys do. So unfortunately, I don't have a firm answer for that. And I'm so sorry.
I understand. Thank you. I just kind of wanted it out in the world here.
I get you.
And Angela,
Well, Angela, thank you for bringing it up.
Mm-hmm.
Yes. I'm going to lean on Beth's slide where her first statement is don't panic.
So. Oh, no. There's no panic here. I just I just want everybody on here, you know, we're a very small community here and we know what's kind of on the line. I don't know about the other providers, but only about 10% of our clients are fee for service. So that's 90% of our revenue that we just need to be a little more aware of, with these transitions. So it's more like opening up for the rest of the providers on the call, that we all just need to make sure that we're careful about this and we're aware, and that it in my opinion, it is a problem that the MCOs are not present in this entire transition.
I wish that they were here to be able to answer your questions.
I know I'm done.
This is Sarah, just to mention, they have been present throughout the process, and they're, like Beth had said, they're aware. We have meetings with them. We have opportunity for questions. They're on public workshops as well. So they're hearing the concerns. They're aware. They're on the same timelines as we are, especially with those bundled codes and rates coming down the line in the future. Some reason you magically got muted.
Can I speak up on behalf of Nevada Healthy Blue? We're in one of the managed care. I'm Dr. Barrera, substance use disorder addictionologist, medical director. And yeah, we share concerns. We've been active in all of this, getting ready, prepared, patiently waiting, just like you guys, for, to just move forward. We're ramping up all sorts of services and training. So just we are available to reach out as soon as we have the info. We're going to be on track. Same process, and have asked for some patience in that transitioning over with the new provider type. There will be a little lag, obviously, from the state to us, but we expect it to be as minimal as possible. We want to get things going, just like you guys. So thank you, and we will have our contact information with Beth, but we're also very in communication with her as well.
Thank you so much, Dr. Barrera.
And I just want to echo those sentiments. This is Dr. Hollister, the Behavioral Health Medical Director for Molina, Nevada. We are engaged in this process. We are at these meetings. About to drop my email in the chat. Please send your questions and I'll make sure we get them to the right people.
Perfect. Thank you, Dr. Hollister.
You're welcome.
And thank you. Thank you. And this is Josh from Health Plan of Nevada, from the networking team. Same here. I will drop my contact information should anybody have any questions. But yeah, looking forward to working collaboratively with our community.
And this is Allison Hoover. I'm with Silver Summit Health Plan, and we're very aware of this and have been working together with the state on changes. I'll put my email in the chat as well.
Thank you all so much. I didn't want to call you out specifically, just letting you know they are on. So
thank you so much for joining with us, MCOs. I appreciate it.
Brandon, okay. I see your hand up.
Hi, guys. Yes, I was just trying to see about some of the licensures. I think it's going to be a little bit of an issue eliminating the therapists that are interns. I know a lot of PT-17s that are structured like that right now, especially doing co-occurring. Either there's a CSWI who's already has that in their scope, the ability to treat substance abuse, or there's CPCIs/MFTIs that also are dual licensed interns, they're CADCIs. Now, we did the training the other day. I understand that the enrollment system is going to be set up that they could actually enroll twice under their same MPI, that they could enroll with a 14 as a QMHP, and then also re-enroll now as a PT93 with a CADCI. I think that's a little cumbersome, because it's kind of like doing it twice, and then we're also enrolling them at a lower licensure on one side. But at the same time, then I think the CSWIs, it causes more of an issue with and eliminates them or forces them to go get this other license. I see a 705 out there as well, the LCADCI. I don't believe that is actually one of the credentials that you can receive. When they get that C, that clinical, and they go from a LADC, that they're fully licensed on both sides. So I'm thinking maybe there's some room for the QMHP 300s to be in at that 705 instead of that LCA DCI.
Brandon, I can appreciate your concern about losing the ability to utilize the CSWIs, the MFTIs, and the CPCIs in your settings. With regards to the LCA DCI, this was the latest information that was provided by the Alcohol and Drug Counseling Board. If that has changed, I will certainly reach out to them and double check. But as of the last time we checked, this is the information that the board gave us. So I don't have the ability to put in the 14300s in the 705 spots for the QMHPs. I've talked with some clinicians, Brandon, who are the interns, the CSWIs, and specifically, and it's kind of a mixed bag. Some of them really are super excited that they have the opportunity, and they're being encouraged to pursue dual licensure, and I think that's great with the substance use treatment. It's specialized, and so that's why if you're going to treat substance use, you need to be credentialed to be able to do so. So I hope.
So the intention was to kind of push this through to make interns get dual licensed then.
To be specialized in the field that they're providing services, to make sure that the right services are getting to the population that's intended to be treated.
Okay. I just wanted to make sure it wasn't like an oversight and it was going to cause backlash because there was a lot of people that are doing it already, but now they have a chance, then they know, okay, this is the direction the state's going. We want everybody dual licensed, regardless of what school you came from. Let's go ahead and this is the way it's going to be. So
go ahead.
I would request that you verify 705. I believe that there's an extra C in there. It should be LADCI. But again, I would check with the board.
Okay. Thank you for that, Jason. I appreciate that.
No problem.
Thank you.
Of course, Brandon. Thank you. Any other questions before I pull up MSM 4100 and we can look at that if you have specific questions or want to see a specific section? It's in draft form. It's not approved, which is why we're having a public workshop. So
I won't jump on, I'll jump on the positive side of the bandwagon, if I may.
Sure.
The question I have is obviously, and I appreciate the health plans being on. I guess the question where some clarity will come eventually is around, like others have mentioned, the prior authorization process for the plans, right? So you all at the state are looking at prior authorization, and I think Sarah, you mentioned something about possibly 30 days. And so getting that process clarified of what the expectation, and it may vary based, by plan, it may vary. And so, having some clarity around that. And if there are going to be, like other states have done, limitations to that. I mean, I know 30 days was thrown around, but some states are authorizing 14 days initially with, a requirement for a continued auth request. And then other states allow initial 30 days for a continued auth for a potential up to 60 days. So it can vary, but just understanding that process, because there's a lot of, as you all know, a lot of administrative burden that wasn't there prior to this implementation that we will have to account for from a cost perspective, right?
So is it helpful, Jason, to share that we received that comment prior to this public workshop and have made that change in MSM. So what I've pulled up on the screen is the latest version that I have of the MSM 4100 draft, and you can see that the prior authorizations for 3.1 and 3.5 have been increased to 30 days, but the 3.7 WM remains at 5 days.
That's good. Yeah,
that looks good. Okay.
Yeah. But I mean, I guess the last thing I'll add is, my understanding is that the plans can be less restrictive and not necessarily more restrictive than state Medicaid. That's a true statement, right? So that's my understanding. So the question becomes is then it's a guaranteed, if it's written here and that state Medicaid is saying that it's a 30-day automatic 30-day for the initial auth. I'm assuming, I hope that that's what will translate to the plan, to the health plans, right? So they're automatically authorizing an initial 30 days. And then it would be up to us to convey medical necessity if there was an additional continued auth state request. Right?
That is a fair question. I would open the floor for if one of the MCOs present wants to answer that or would like to address that at a later time, if you would let us know.
This is Dr. Hollister with Molina Healthcare. Our discussions haven't gotten to the point we actually were hoping to have this meeting and then revisit. So we're not at the point where we've set what our limits will be for approval. That's an ongoing discussion.
Fair enough. Thank you.
Thank you, Dr. Hollister.
That's all I have. Appreciate it.
Perfect. Thank you, Jason. Angela, I see your hand.
Yeah, sorry. Kind of picking back on what Dr. Engel said with the health plans. So our questions in the beginning were, what does the credentialing requirements look at from the MCO's perspective with these changes? Since the MCOs are on this call, is anybody willing to come forward and let us know if we're going to have to re-credential all of our staff? What that looks like and what those timeframes are, because I know I've been told in the past, and I've actually seen in the past, it's taken me 120 days to credential one staff in the past, sometimes longer. So that's something that we need to be aware of too with this transition coming. Can we ask that question to one of the MCOs?
Hi, this is
I
Josh
can
from
chime in.
HPN. So no, with us, you would not have to re-credential. As long as your facility or your providers are credentialed with us, then there would be no additional changes on our side with respects to credentialing.
Thank you.
That's good news.
Does that also, though, because it's
excellent news.
It's
excellent news.
The way that we credentialed them before weren't necessarily aligned with the way that it is with the new provider type now with the 701s and 703s. So is that going to cause any problems when we start submitting claims under the new credentialed providers that are credentialed in that way with a Medicaid number?
So we will have to revisit the agreements and we'll get those templates out to to each of the groups as quick as we can. With credentialing, yeah, I mean there wouldn't be a need to re-credential, but yeah, the agreement we definitely want to revisit to make sure that the agreement aligns with the new with this new structure.
Thank you, Josh.
You're welcome.
I could take a breath with that answer. I've been asked these questions for a while, Josh, and I didn't have the answers. And I'm like, I don't know. So thank you. I appreciate that.
Yeah, that's excellent news. Thank you, Josh.
Welcome.
What other questions, what other sections of the policy would you like to see or run through or have questions about?
Or two or no?
Or two.
I have one last question and then I'll stop. So is it a bundled rate, meaning that if I have an individual who is looking, if there's a psych eval needed, it says right there, medical psychiatric. Okay, I guess I need to look at it. I'll stop. I'll talk to Ange outline, but I'm assuming it's bundled, right? It's all inclusive, Ange?
For residential, yes. I've read the chapter cover to cover, Dr. Engel, so we can meet.
Got it. Thank you.
I'm gonna make this just a little bit bigger. Hopefully I'll make it a little bit more comfortable for those in case it was too small. I
So-
appreciate the conversation, so thank you. Esther, go ahead, I'm sorry.
Sarah or Elizabeth, the concern in my mind is this. Co-occurring SUD, about what are we speaking in this provider type 93 or both?
So sorry.
No, I was
You
gonna say,
wanna
I
go?
wasn't sure that I understood, so go ahead, Sarah.
So under our 1115 authority currently, Medicaid's only allowed to reimburse for SUD treatment for an individual with an SUD only diagnosis or a co-occurring diagnosis, but it has to be SUD treatment. We're looking to amend the 1115 to add in the SMI population to allow for psychiatric treatment. But that's further down the road. So the treatment has to be SUD focused. Does that answer your question, Esther?
Yes, thank you.
Mhm.
Thank you, Sarah.
Wendy, looks like you've got your hand up.
Thank you. My question is regarding the slideshow,
Okay.
that page that you're on, just seeking clarification that it is the intern level licensures that are going to need that dual license.
Yes, it would be, but it's for the interns who aren't listed on the chart, Wendy. So specifically, it's your social work interns, your clinical social work interns, your marriage family counseling, or I'm sorry, your marriage family therapist interns, and your clinical professional counselor interns.
Thank you so much.
Of course.
So I didn't see medication assisted treatment on the bundled rate. Does that mean that we can bill?
You are right, Dr. Engel. We've requested to remove the medication assisted treatment out of the bundled services so that that service can be billed individually.
I would like to request the cost of psychiatry. I would like to request that you remove psychiatric evals out of there too.
Okay, I will take
That's not
note of
gonna
that.
happen, but I mean, if you think about it, in a lot of cases, it's, done through an MOU or a community partner. They bill that external. So, right. So you have somebody receiving a bundled rate in SUD treatment. It requires a psych eval. You don't provide psychiatric, you have a partnership with a community provider. When you send them to that community provider to do the psych eval, they're billing their Medicaid. So it's in most cases being billed anyways outside of the bundled rate. And the cost associated with that provider type, it's unsustainable to have it bundled in to the rate, in my opinion. That's just my opinion. So having things like MAT external being billable as well as psychiatric evaluation external from that would be, in my opinion, would increase
Sorry.
sustainability. So that's the last comment I have. Thank you.
Okay. Thank you, Dr. Engel. I appreciate that. I don't have an answer, but I have taken your note with regard to that specific service. Let it marinate a little bit. I know this is a lot to take in. This is a monster change.
I would just like to say thank you to all the work that you've all done on this. I know we're all a little apprehensive about this, but I believe it's a step in the right direction. And I think that, over time we'll get the kinks worked out.
Oh, I appreciate that so much. Thank you for sharing.
Beth, I did have a question. This is Sarah Paulson from Anthem.
Sure, Sarah.
Yeah. And I know, and as you said, we have been working with you and, again, kind of evolving everything as we go, right? Like a lot of things are still fluid in so many ways. One of the things I wanted to ask, if you wouldn't mind speaking to, is that transition period, right? Like I know that we had talked about during that interim phase that there would be a continuity of care that we would both be, of course, working with the members. So it's not a hard stop. Would you mind speaking a bit more to that, how that will look?
What that looks like?
Yes.
Okay. So if I understand your question, Sarah, I'm gonna start answering it. If I get off track, please reel me back in, okay? Because there's a lot of information in my head and I want to make sure I'm addressing what you need. So on July 1st, when the application becomes live, at that point, what can happen is providers can go out to the portal, retrieve the application, start the application process with Nevada Medicaid for their groups and for their individual clinicians. Your provider type 17215 will continue to be active until your 93 is approved. And at that point, what will happen is, let's say John Smith has a prior authorization for therapy services, and he has 10 therapy services or units left under provider type 17215. When you take John Smith, now you're provider type 93, what you'll need to do is keep track of your prior authorizations and submit new FA11s for those services. John Smith's services don't start over with provider type 93. The 10 units that remained under PT 17215, those same 10 units are going to be requested now on your PT 93 prior authorization request. So on the form, you'll need to indicate dates of service and number of units requesting. So it doesn't start over. It's just a continuation of that. Sarah, is that what you're asking about?
Yeah, so that's very helpful for the provider type changeover. I think the question is for the members who are currently working fee for service, they're currently in residential treatment right now, right? And so that switch to, yeah.
So the services, I believe, Sarah, again, step in if I'm wrong. The services are until the bundled rate is approved, can be billed individually for the individual services. The codes are still available in the billing guides. The billing guides mirrored what was currently existing for 17215, 17171s. And the 704 population was extracted from the 17215 for the level 3 services and built and just put onto a new page for 704 by itself. So Sarah, direct me again. Sarah Paulson, sorry. Direct me again. Is that the question? Like, is there more to the question that you were looking for?
Yeah, let me take it away. I know we have a conversation already ongoing, Beth, and you've been so wonderful in working with us. So let me put it into the context of what we had been previously discussing, because it may be specific just to us. Yep.
Okay. Angela?
Yeah, sorry. I wanted to see if we can look at chapter, I don't know what page it says page 26, but I know it's not 26. It's in regards to
sentence of what you're, I would say, give me a sentence of what you're reading and we'll find it.
Partial hospitalization.
Okay. Okay.
And specifically section, that's under that's 2, section D.
This one, these services are furnished under a medical model?
Yes.
I just, your comments.
Yeah, I just wanted to bring up that even though the services are furnished under a medical model, it's listed by a hospital in an outpatient setting or an FQHC. CMS doesn't have any regulations that says it has to be done in a hospital. They just have to have adequate medical staffing. So I'd like to see if that can be taken into account. ASAM also doesn't have it listed that it must be a hospital or an FQHC. So if we can have that align more to ASAM, that would be great.
Sarah Dearborn, do you have any thoughts?
I do. I think, excuse me, I think we can look at our current state plan language. I would need to look at this again, but we have to follow what's approved in our state plan, and I believe the intent of PHP is not necessarily require a hospital to provide PHP or an FQHC, but that second sentence related is if the provider's providing that level of service, they must have a contract with a hospital or FQHC. So I see what you're saying, Angela, and I think our language might be a little confusing there. Because the intent is not necessarily to require a hospital to provide it, but we need to make sure a PHP provider has the ability to transition an individual to that hospital setting in the event they need it immediately.
Understood. That language would be much more clear. Thank you.
Okay, thank you for that. Because I did look in our, I forgot to, I think I forgot to follow back up with that. I did look in our state plan. This language does appear to come from state plan, but maybe it could be clarified a little bit more here. So I'll take a look at that as Sarah suggested.
Yeah.
Thank you
And
for
Beth,
bringing that back
you
up.
did follow up. You did follow
Oh,
up and let me know.
Whew, good. I shook my head. It fell out. I forgot.
Thank you.
Thank you. Of course. Okay, so any questions? I know that Gainwell has the trainings that are scheduled if you haven't yet gone out and to their training enrollment site to enroll in their workshops. I highly encourage that. If there's anything, any other questions that might be of interest to you. We've talked about kind of like with the rollout of PT 93, we've talked about the go live date, the effective date. The next steps for us is the CMS submission for the SPA package, which is 4 parts. The prior authorizations during the transition period up through March 31st of 2025. Angela?
I'm sorry, I just remembered one more question that came up in a staff meeting. And I don't remember seeing it in the chapter, but if it's there, please let me know. Are there any documentation guidelines for residential? Right now, we're used to doing, I think, 2 notes a week, one that covers all the group hours, one that's individual hours. It keeps the administrative burden down. Do we know if that's changing at all?
And this is for, you're asking specifically for residential?
Yes.
I don't think documentation was split out according to level of care. Is your recommendation that it should be?
Not necessarily. My recommendation, sorry, excuse me. My recommendation is that it mirrors what we're already used to, kind of with our documentation standard from SAPTA, which is one note entered for the 6 days of groups, which covered all of the needed hours per ASAM for either 3.5 or 3.1, which we're already documenting that way. And then one note for individual rather than documenting every group every day. I think that would absolutely break our infrastructure. And I welcome the other providers to please give their however they feel about that.
So on the screen is what is currently in the draft version of documentation requirements. Is this?
Beth, can you scroll down a little bit? Does it specifically go into progress notes?
Yes, it does. Oh, okay.
So this is pulled directly from chapter 400, which is the typical progress note requirements that we have. So are you recommending something different, Angela? Because it seems
yes.
like our requirements are really, and a lot of that is based on, how can we tell that services are being delivered based on a bundled code, basically? And we need to know if you're saying services are delivered every day and we delivered group 2 times in that day and peer, like we would then foresee, okay, if we went into a medical record, we would see indication that that happened, that exact thing happened, in order for a billable code to be reimbursable. So we may talk a little more with SAPTA about their requirements on that, but these are our typical Medicaid requirements for progress notes. So we may need to look at that a little further.
Yeah, and I do have a few of my residential staff for West Care, Nevada on this call, and they may have some ideas. I know that I can see Brody and Edgar in my screen, so I don't know if they maybe wanted to contribute to this portion.
I'm sorry, we were discussing how to demonstrate that we've given X amount of services on a given day, correct?
Yeah, so how would your documentation look as far as, you're billing for a bundled code? On the Medicaid side, we need to know what services are delivered during that day. And how does your documentation reflect that?
So typically what we've done with SAPTA is we have a general a group note that we use every week, and it says groups offered this week, and we list out every group the counselor did. And then it's broken down by whatever the evidence-based practice is. So whether we're using like the matrix model or strategies for change, right? It says matrix, and then it says the topic of the session. And then when SAPTA comes, we also provide them with our group schedule, which demonstrates on Monday, the clients will do matrix at 10 o'clock and 1 o'clock. On Tuesday, they do this curriculum at 10 and 1. So we could, if that would be sufficient enough to provide the managed care organizations that demonstrate proof of services, or we could break down the group notes into like Monday, these groups were offered. Tuesday, the clients attended this group. Wednesday, the clients attended this group in the weekly note.
So it's sounding like there's definitely differences between what SAPTA requires versus Medicaid. And so thank you for Angela, highlighting that difference. I'm not sure how amenable we can be to changing Medicaid requirements on progress notes, but we can definitely work through that and try to brainstorm if we need to amend this language.
I will add, I believe that if it's a daily billable service, it requires a daily note. So we can discuss that offline with the team, but that's just Medicaid rules.
And although I completely understand that, I think that it will be overwhelming for that transition to happen so quickly, because that's retraining staff. I mean, we have a hard enough time getting our outpatient counselors to get their notes in on time. I couldn't imagine what that would look like on a daily basis. But again, I'm not a clinician, but I would just appreciate, if there are other providers on here that, could understand what that volume would be, what that workload would be. We have a lot of beds. We have over 120 residential beds. So that's a lot of clients. That's a lot of notes.
Yeah, and at the same time, right, we said it would all be billed under the primary clinician. Well, I'm not the clinician doing group with that client every single day, right? So they're seeing multiple providers. So am I putting in documentation for someone else's group, but at the same point, how can I make an assessment of the client's behavior and understanding of the group curriculum if I'm not the one who was in the room with the client during group?
Right. And so I'm definitely not saying that you would be like doing notes outside of your scope or anything. It would be a note would be required for the service that you or the individual provided. irregardless of if you are showing as the performer on the claim, the person responsible for the service. If a bundle code was provided that day, then your medical record should show the services that made up the services for that day. Whether it was a peer and they have their separate note, or a group counselor was running group, they'll have their group notes. That's how it works currently, like with IOP and PHP as well. So that's how I would see it.
I guess the thing that concerns me is that most of the claims, right, for Medicaid would be whoever the service is billed under would be the documentation would align to that, right, for auditing purposes, which I see where that would create a challenge if it's in a residential setting where there might be multiple providers. Having that one individual that it's billed under do 170, notes a day is not realistic,
Right.
I guess.
And I would agree with that. So that's where it would be helpful to have your individual providers doing their notes. Perhaps the clinician that's overseeing the model is maybe signing off. That would be more agency specific.
That's a good recommendation. Yeah, that would work. That would work.
The goal is for that Medicaid understands what services were provided to that recipient on that day. For us to know, okay, that an agency billed for this code, they're getting this much money. Well, was a service billed or was it multiple services that were provided? That's stuff that we look at.
So some states, and you may consider this, some states allow for a weekly note, right? So it incorporates the full week based on the number of hours associated with the level of care, right? So you have a specific number of hours in 3.1 and 3.5 that justifies that level of care. However, given that it's a daily rate, is where there may, you may not be able to be flexible in that requirement, but it would be something that you may consider. It would be, as Angela mentioned, it would be a tremendous lift on an administrative burden for the residential providers to be able to do that.
Well, that's helpful insight. I think we can definitely look at the policy that we have currently. We're happy to look at kind of how some other states are doing that as well. We're definitely going to have a process with CMS as we work through approval of the bundled type of service. So we can also access their help as well.
This is Dr. Burrow again with Anthem. Just a thought with documentation. I know, and having assisted in other states, going off of ASAM, they do recommend different documentations like weekly for residential 3.5, monthly for 3.1. And when we're looking at those notes, we do want to see them attending group or not, but really we're looking for gaps in care. We're looking to connect the dots. We want to fulfill our contractual agreements to ensure that there's no gaps for our members. So that's really where the documentation is going to be, where are they in those 6 dimensions? Where can we assist in those? And then we will be kind of, at a little bit of a disadvantage if we're getting, concurrence every 30 days. We're really going to be trying to catch up and making sure, are the cadence of the services, appropriate? all of that, and just aligning, getting those case managers involved as quickly as we can. And if we know it's a, difficult case, those sorts of things. So just another perspective. Thank you.
Thank you for that.
I think that's helpful.
Mhm.
Okay. So we have some, we'll take these notes back on the progress notes. We'll reach out to SAPTA. This has to go through CMS approval, so we'll work with CMS too to kind of see what that requirement looks like as well. But we will certainly take these these concerns, ideas, and suggestions into consideration. Okay, it is 12:07. My contact information is here. Also, the behavioral health web shared inbox is there. I encourage you, if you have questions, email is the best way to reach me. But I am available by email, by phone. If you have questions, if you need to run through something again, you want to see something again, talk it out a little further, I'm always available to meet with you to get your questions answered. So.
Yeah, hi. Is now a good time for a question?
Absolutely.
Hi, this is Philip Ramirez calling or speaking from Molina Healthcare of Nevada.
Hey,
and
Philip.
We're aware that earlier this week, DHCP provided us with the PT93 residential codes, the proposed residential codes and rate chart. And I was wondering if those have been finalized at this point. Yes, this is here, or when that is expected to be finalized so that we can start to execute on those new rates and codes.
Perfect, Philip. Thank you. So the rates have to go through CMS approval. We can't actually bill these three codes until CMS has until we've gone through the approval process with CMS. We're requesting an effective date for be July 31st, meaning once CMS approves the bundled rates, we can go back to July 31st and pay claims up to that point. But all of the individual services are listed in the billing guides currently as, and the codes are available to be billed. I know that that's a lot, which is why obviously Medicaid has requested the bundled rate. So, but that's the workaround. I'm new to, I should have started that with, I'm less than a year in Medicaid, so I don't understand, so I appreciate Sarah being on the call. If there's a question like how the back billing works, I don't quite understand that, but the effective date we are requesting is July 31st. Philip, did that answer your question?
It does. So,
Okay.
basically nothing has changed at this point until these rates have been finalized.
That's correct with regards to the bundled,
Awesome.
the proposed rate.
I see
Yes.
Sarah shaking her, and so we're good.
Yep. Okay.
Or nodding rather, excuse me.
Okay. Oh. Okay. Just scrolling back to my contact information. Then if there are no other questions, I will let you guys get back to your day. I know everybody's extremely busy. Please feel free to reach out to me if you have additional questions, comments, want to see anything, want to have just a discussion. I'm available and willing to meet with you.
Thank you so much, Beth.
You're welcome, Angela.
Thank you,
Before we
Sarah.
go, I see Dr. Morgan has her hand up. Maybe. Are you muted?
Sorry.
There you are.
Okay. Sorry. I was like, I'm still working clinically. Thank you. Thank you guys for all this information. This comment, I just wanted to make a public comment because it didn't really apply to provider type 93. But I did want to bring up that within the EMS circles and under provider type 32, which is all of EMS transport, currently there are efforts being moved forward nationally to start to initiate MAT with buprenorphine in the field in the pre-hospital setting. And so I would love to encourage that topic be added to future public workshops to consider potentially an unbundling of the initiation of MAT, similar to what you guys had talked about here, because currently that's like everything that's done in the pre-hospital setting is bundled within provider type like 32 reimbursement rates. And in an effort to continue to increase accessibility to buprenorphine and other medications for opiate use disorders and other substance use disorders, there's been a push into the pre-hospital setting, and we're trying to continue to enhance the continuum from pre-hospital into the emergency departments to help be able to transition people in that outpatient setting. And so would love to start or at least put that on the radar for future discussions. Thank you.
Thank you, Dr. Morgan. Okay. Anything else? All right. Thank you so much. I look forward to working with each of you and having conversations as need be to help this transition go as smooth as possible. Everybody have a great day. Of course.
Thank you, Beth.
Bye, you too.
Of course. Bye-bye.
Bye.